So first, I would like to invite Dr. Daniel Toshio Herald to give his keynote presentation.
Good morning. My name is Daniel Toshio Herald, and I'll be speaking to you today on the barriers to digitization and health information that we found in Kenya and Laos. I'd also like to thank you for the invitation to speak this morning. This is a brief introduction. My name is Daniel Toshio Herald, and I'm currently a research fellow and a project IT coordinator at University of Texas Dell Medical School, and where I do mostly research in solving healthcare interoperability in the city of Austin, Texas, and also do project coordination for COVID contact tracing in the city of Austin. I got my PhD in medical science at Nagasaki University, where I also did a research fellowship in ecoepidemiology, in which I implemented and designed EMR systems for Egypt, Kenya, and Laos. And the subject of my talk today will be from this experience. Just a brief outline of the presentation. I will discuss a little background on electronic medical records, or EMRs, in global health, the development of our custom integrative material and child healthcare system that we used in Kenya and Laos, and discuss the barriers that we identified from interviewing local health professionals, which included doctors, nurses, and community health workers. So, as I'm sure everyone, you are aware, electronic medical records have come a long way. They beginning in paper form with very large rooms and transitioning to being able to be accessed through electronic devices. As a generality, electronic medical records have simplified the management of patient information. They've increased productivity in clinics and also enhanced information available to physicians. A whole room is now available through a mobile device. As healthcare is moving toward digital standards made available by this digitization, new fields have opened up, which include telemedicine, which has been crucial during COVID-19 pandemic, as well as real-time and self-care, where patients can report outcomes directly to the medical record. During this COVID-19 pandemic, there's the need for more coordination between clinicians and patients has been highlighted, and the coordination between the medical records and health organizations as well. In my capacity at UT Health Austin, I helped implement a GoData contact tracing implementation, which has helped us keep our campus safe and help report our COVID cases to our public officials. On our campus, we also have mobile apps that are able to use Bluetooth to help notify folks if they've been recently in close contact with a COVID case. I just would like to talk about EMR adoption in the United States, where I am now. Since 1992, the U.S. National Academy of Medicine has recommended the complete digitization of healthcare data. And as of 2019, 99% of eligible hospitals have demonstrated meaningful use of EMR. According to the ONC, which is the Office of National Coordinators for Health Information Technology, the state with the lowest adoption rate is North Carolina at 96%. And while most of the records in the United States have become digital, there's still a number of issues, including interoperability. However, in 2020, the U.S. Center of Medicare and Medicaid Services required the use of FHIR, which is the Fast Healthcare Interoperability Research, to standardize and improve interoperability between providers in the United States. This is where most of my current research, the subject matter for that. As far as in for developing countries, healthcare, digital health and EMR development and adoption has been highlighted as a key component to achieving the UN's Sustainable Development Goals, particularly number 3, which is to ensure healthy lives and promote well-being for all and all ages, or at all ages. But however, during the past 20 years, many developing countries have attempted to digitize their healthcare systems, but there's been limited success. And the most complex barrier to full adoption have usually been attributed to organizational, which includes human resources, technical or infrastructural issues, poor data quality and reporting, and then political pressures. And the COVID-19 pandemic has also increased this global adoption in high and digital health technologies. However, in Africa, as an example, the adoption has not been as successful. So our study was to, our lab's research aim is to develop and evaluate healthcare applications for data collection, monitoring, and analysis for epidemiological studies in low to middle income countries. And in this project, we wanted to understand the current barriers and challenges to digitization that was experienced by our healthcare workers in this clinical setting. So at Nagasaki University, we have been developing a health and demographic surveillance system, which establishes a longitudinal data collection process for low to middle income country settings. And health HDSS is a surveillance methodology that's community-based that acts like a census. So in a defined area, we want to track births, deaths, in and out migrations, and then disease prevalences. We collect this data by going house to house with surveyors who every 3 to 6 months collect data from every family within the area. And so as of today, Nagasaki University has operational HDSS sites in Kenya and Laos, in Kwale County, which is in the southern part of near the Tanzanian border in Kenya and the Indian Ocean. And then in Savannakhet province in Laos, which the city is on the Mekong River near the Thai border, but the province extends to the Vietnamese border. For this project, we wanted to see how, if there were other ways besides house-to-house assessments to collect births and deaths. And so we focused on births for this project. As a model for the data, how to collect antenatal and MCH, maternal and child healthcare data, we used what's called a mother-child handbook. And these books track the continuum of care between from pregnancy to child health care. They have guidance on nutrition, breastfeeding, and child development, but also collect medical data from antenatal visits, from the birth, child's immunization records, and growth monitoring. Japan has been a leader in the development of this handbook, starting in 1942 with the first pregnant mother book. And then in 1948, the development of the mother-child handbook, Boshi Techo, which Bo is a mother and Shi is child. And this book was created because the infant mortality rate in Japan after World War II was about double what's experienced in the United States. And so with the introduction of this book, by 1970, the infant mortality rate had dropped to match the Western world. So this book has been a very cost-effective way of improving child care. Since the 1980s, JICA, which is the Japan International Cooperation Agency, similar to USAID, has implemented has helped implement similar programs around the world. In Africa, currently 11 countries have a nationalized mother-child health book, 11 Asian countries as well. JICA also assisted the Netherlands and the state of Utah in developing their own handbook programs. Currently around the world, there's also pilot programs in South America, Africa, and Southeast Asia, with India, China, Turkey, and Nigeria in the planning stages. So at the moment, about 40 countries are using either an official program, a pilot program, or planning to start a handbook program. Within the countries that use this JICA-inspired book is Kenya and Laos. Within Kenya, most of the medical records are still paper-based. We have within the hospitals, there are registry books that are from the Ministry of Health that track antenatal care, immunization records, as well as demographic records for mothers. And then they also have the mother-held MCH books, which are brought to the hospital by mothers for every visit. Nurses have to, by hand, write into all these registries during every visit to keep the medical record. So we try to imitate all these records in a digital format using what we call the Mother and Infant Registration System. And this, which was accessed via computer and was used by healthcare providers during the point of care in Kenya and in Laos. The wire system had two types of profiles. It had mothers, which had demographic information and geographic information, which were linked to an infant profile, which also had their demographic and geographic information. All mother profiles had a medical record, which was based on their ANC visits. And then an infant profile would have growth monitoring reports, as well as vaccination history and an alert system that would notify nurses when a vaccination was due. Due to most deliveries in Kenya and Laos being at home, we created a separate report that was linked to both mother and child that could be done in delay. Once the mother came to the clinic once the infant came to the clinic for the first immunization. To design WIRE, we took a community first design process. So in order to design this system so it would integrate seamlessly into our areas, I visited Kenya to observe clinical workflows at all levels, which are district hospitals, healthcare centers, and dispensaries, and then interviewed doctors, nurses, and community health workers, and to understand their current user experience with the healthcare system or with the record system, as well as reviewed mock-ups with them to make sure that our system was compatible. I also interviewed mothers with various social economic groups to understand their experiences within the healthcare system. After this requirements acquisition process, we developed it locally in Japan, and within 2 months, we're able to install and implement the system in Kenya and in Laos. So we had nursing seminars where all the users, so that's mostly nurses, would visit and we would go through a training session and then followed by in-clinic visits with each of the nurses to make sure they understand how to use the system, and then had 2 or 3 days of actual patient interactions to make sure that the workflow was compatible with the clinic and to debug any issues that came up. So currently we have 2 independent wire systems, one in Kenya, which is in English at 5 hospitals in different levels, starting in January 2017, which had a study duration of 21 months. And after 21 months, we have enrolled about 13,000 mothers and 10,500 infants. In Laos, we localized the notebook, our wire system to the Lao language. And installed it in 5 different clinics, which starting from August 2017 and had a duration of 31 months. In that time, enrolled 7,000 mothers and 3,500 infants. One of the things about our study sites is that they're actually geographically very far from each other. In Kenya, they're about an hour. The furthest hospitals are about an hour and a half apart, and in Laos, about 3.5 hours by car. So geographic limitations were also needed to be resolved. This is why we used a cloud-based system that's centralized to a single Windows server that connected clinics via 3G mobile internet. The reason we needed to do this was because in both countries, there is mothers and infants tend to visit multiple hospitals, and healthcare is also at home. And so mothers can get their antenatal care at a hospital, deliver the child at home, and then get immunizations at a nearby community clinic. So using our cloud-based system, we were able to capture this migration. This actually became very handy when we had a mother who needed an emergency C-section but was able to be transported from community clinic to a hospital, and the records traveled with her when she arrived via ambulance at the district hospital. So we set out to analyze the barriers experienced by our healthcare providers in implementing the WIRE system. The interview, we had a cohort of 20 medical personnel. The majority were nurses and then midwives, doctors, and community health workers. And in Kenya, due to workload at certain facilities, we had to hire WIRE operators, so we had their perspective as well. Altogether, we had 10 interviewees from Kenya and in Laos. The interview questions were designed in English and then translated into Lao and Swahili by local staff. And then after the interviews were conducted, transcribed in the local language. In Kenya, they have a lot of code switching between English and Swahili. So we transferred straight to English. And then from there, analyzed the English translation for themes. For the questions that we asked, we used mostly asked about ease of use, whether mothers were open to enrolling themselves in the program, whether there was an increase in antenatal care from the introduction of the system, what benefits or difficulties were encountered by our staff, and then if our staff perceived any benefits from having that the WIRE system could contribute to the current maternal and child healthcare system. And then we also asked them for new features or recommendations for future versions. After analyzing the transcripts, we found that we had 6 general themes that regularly came up. First was the satisfaction with the system, mothers' resistance to the WIRE system, a need for additional training, the perception that it contributed to double work, a need for better working environment, and then a need for improved resources at each of the clinics. The most prevalent theme was the double work perception, followed by satisfaction of the system, and then a need for better internet connectivity for WIRE. In Kenya, there was also a high prevalence of infrastructure improvements that were needed. So I will first discuss the perceived benefits of using WIRE by our healthcare providers. For ease of use or improved usability, generally the nurses reported that it was easy to use and quick to get used to. One of the things using electronic systems, you can use an auto-populate function. And so half the data did not need to be rewritten. It would auto-populate into each visit. And so that increased efficiency overall in the system, in workflow. Also, they perceived an improved interoperability between clinics. And so as this nurse reported that they had received clients from other clinics, as well as in summary, it was useful for the continuity of service to see one facility to another. Also in Laos, due to community outreach being a very prevalent way of distributing healthcare, with patients' demographics in the system, they were able to determine which villages they needed to go to next to give out vaccinations. As far as the first barrier, or the most prevalent barrier, was the perception of double work. In Kenya and Laos, nurses have to add medical records to the mother-child book and to registries, and then afterwards also contribute to the WIRE digital system. And so given that this was research, they had to do all three. And so they had to satisfy adding the data to the WIRE system, as well as reporting by paper to the district hospital. While the computer was easy to use, it just added more work time. And so we need to work on WIRE's efficiency to make sure we can cut down on this double work. However, for a new feature that they requested, they did ask to generate a summary report out of the WIRE system, which will allow them to contribute to the registries in a more efficient manner. Another barrier was a lack of familiarity with WIRE or electronic medical records as a whole. Mothers were very nervous seeing unfamiliar systems, but mothers always trust the nurses. And after some explanation, they would feel free, they were comfortable contributing data. They would always wonder why this wasn't implemented before, and so we're a little hesitant. With electronic medical records, there's always a confidentiality and privacy concern, which contributed to the hesitancy. And for HIV positive patients, they were very nervous to contribute their medical records. In Kenya, there's a history of HIV positive registries, and so the surrounding environment made mothers nervous. As far as, and then nurses were also kind of unfamiliar with electronic medical records. So we needed to really improve our training, because many actually weren't familiar with how to use PCs or mice. And so with regular training and follow-up training sessions, we were able to remedy this barrier, but also improve performance overall. And we also need to train other employees besides our staff for this, using the system, so that in moments where the clinical had a lot of patients, they could support their colleagues. But in a lot of our situations, the unfamiliarity caused a barrier to help. Another barrier is a lack of infrastructure. Given that it's a cloud-based system with a central server, this system relies on having power and having internet. But when in Laos, particularly in Kenya, during the rainy season, internet signal could be low, causing performance issues, which contribute to frustration for the nurses as well as mothers. In addition, power outages are a regular occurrence. For instance, in this dispensary, it runs mostly on solar panel. And so we provided additional power supplies to make sure that the systems could be charged. However, if there was sustained power loss, we would lose functionality, and again, frustration may grow within the staff. And so improvements to internet connectivity and power infrastructure are a necessary addition to EMR implementations. In addition, clinical resources are also necessary. We had a few devices that were stolen out of clinics, and as well as nurses may be nervous having computers with them in clinic. And so being able to create a more safe environment at each clinic was a necessary measure. And then given that this is research, we did offer financial support to our users. And we found that that often correlated with performance. And so the necessary training as well as necessary support is necessary for all staff. Our findings were recently published into the International Journal of Environmental Research and Public Health, with the PI being Professor Satoshi Kaneko of Nagasaki University, and then Tarek Numer, who recently got his PhD in this field. Before I conclude and open the floor for questions, I would like to acknowledge our nurses, doctors, and community health workers who help make this possible. Without them, we would not be able to implement the wire system, and most usually they are the people who get the least recognition in the healthcare system. And so I would like to commend them for their efforts as well as thank them for their contribution. To conclude, healthcare providers and communities need to be the guide for the design and the development for future EMR systems for successful adoption in low to middle income countries. EMR design and implementation must focus on improving patient and healthcare provider familiarity and address clinical infrastructure issues. Also, given that we're in a global pandemic, we need to overcome these barriers so that EMR systems can assist our healthcare providers better manage our global COVID-19 response and then vaccination distribution around the world. Thank you very much. I'd like to open the floor for questions.
Yeah, hi Daniel.
Hello.
Yeah, hello. Which is a nice presentation. Yeah, I'm audible. Yeah, hello.
Hello, I can't quite hear you.
Yeah, fine. It is a nice presentation, Daniel. Actually, and my question is, you research in from Kenya, Laos, and you're currently working in US and studied in Japan. Right? What are the differences you find from these three countries regarding digital health? Especially this pandemic duration.
I guess I'll first start with Japan. Well, a similarity between Japan, Kenya, and Laos is a hesitancy toward electronics medical records. They tend to rely on paper, but there is a drive to improve and to adopt medical records as a system as a whole due to geographic limitations. Japan is an island country, and so many islands have small clinics, but often need to send patients to the main provincial hospital. And with the recent introduction of digital medical records, these records can be sent electronically and help alleviate help improve interoperability between locations. I think this is something that's observed also in Kenya and Laos, and as digital records become more prevalent, that interoperability will improve. The US, I think, is a very different environment compared to the other three countries, because interoperability is, whereas the medical record system is heavily adopted, it's very privatized. And so every hospital has their own medical record system, and interoperability is very difficult. As a result, there's not a lot of patients have to bring their medical records to each visit and fill forms repeatedly over and again. And so I think the interoperability is the major difference I find within the United States compared to the other countries that were highlighted in this presentation. Thank you very much.